Excellent. Okay, great.
All right, let me start. Good afternoon, everyone. Thank you for joining today's webinar, Bridging Theory and Practice, Leveraging Implementation Science to Advance Foodist Medicine Interventions. It is my privilege to introduce Dr. Natalie Moise. Dr. Moise is an interest and associate professor of medicine, as well as the director of implementation science research at the Center for Behavior Cardiovascular Health at Columbia University. With over a decade of experience in health services research, she is the principal investigator on multiple federal funded grants, including projects with the NIH, ARC, and PCORI, focused on implementing behavioral health interventions in primary care and cardio-oncology settings. In addition to her research, Dr. Moy served as a primary care clinician at New York Presbyterian Hospital, caring for historically marginalized populations with complex chronic conditions. She is also a dedicated mentor, has published extensively in the field, and plays key roles on several national committees, including American Heart Association's Implementation Science Committee. As co-chair of Community Engagement and Implementation Science Task Force, she is instrumental in advancing Healthcare by Food initiative. We are thrilled to have Dr. Natalie Moise with us today to share her expertise in implementation science for Foodist medicine research. Without further ado, please join me in welcoming Dr. Natalie Moise.
Great. Thank you so much for having me. Can you see my screen, my overall screen, or just the slides?
Just a slide.
Okay, great. Excellent. Okay, I am going to get started. Okay, so just a little bit about myself. Thank you for that great introduction, EJ. So I lead a suite of different types of grants, thinking about developing and testing scalable, mechanistically driven digital behavioral health interventions. And we just had funded center grants. So we're starting to think about how do you infuse implementation science earlier in intervention development, where I think a lot of you guys are right now. So I'm hoping this will be very helpful. So just in case there are folks who don't know what implementation science is, we will define implementation science, review a roadmap for conducting implementation science to improve health equity, and then learn how to incorporate this when the evidence is not strong. So we have two components: when you have very strong evidence, and then I think many of you in the third bullet where the evidence is still kind of emerging. So definitions. I'd love to hear from you guys. If you could think of just one word that you can think of to describe implementation science, what might that be? You can type it into the chat if you'd like. I like that word, realistic. Mm-hmm. Yeah, that's great. It's good. And by a show of hands, has anyone gotten some formal training in implementation science or feels like they know what it is and how you can use it? One person who's gotten some training too. Great. Excellent. Okay, you guys are going to make it much easier for me. Excellent, excellent. Okay, great. So we're going to go through a little bit, and I'll keep this part brief just in case. We have a variety of people here who know what implementation science is and some who don't. So we know that there's this gap between what we know and what we do. And if you think about the kind of translational research pipeline, you have your kind of discovery work, and a lot of you are in the kind of T2 work where you're really starting to think about okay, I need to develop an intervention. What might that be? And a lot of research suggests that it takes about 17 years to go from discovery to real world practice. And in our scientific statement, we noted that it probably takes a lot longer in historically marginalized populations. Number one, because the interventions that we created weren't always created for historically marginalized populations to kind of leverage their assets and address their unique barriers. And these huge implementation gaps remain, right? And so you have these evidence-based interventions, but they're much less likely to be very well implemented in historically marginalized populations. So the difference between implementation science and interventions are you're really at the kind of step where could a program work or does my program work? And I'm getting a sense of could this work, testing and doing some pilot testing, feasibility testing, thinking about doing an efficacy trial where you have a usual care arm where the researchers are doing everything. And an implementation study is you're making the program work in really diverse, large settings. And so technically, the definition is the study of methods, a scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine care, with the goal of really improving the quality and the effectiveness of health services. And so at its core, there's a difference between an evidence-based intervention. So that could be a food as medicine intervention that you're in the midst of developing and hopefully gaining a lot of evidence for, and the strategies, which are the stuff, the bundle, the things that and types of interventions that help people and places follow that evidence-based intervention. And the outcomes that we really care about are things like feasibility and fidelity and acceptability. By having this strategy in place, did it make it easier for lots of clinics to follow this food as medicine intervention or any other evidence-based intervention? We also look at service outcomes like sometimes, like can we maintain the real world effectiveness that we saw in the original perfectly controlled clinical trial? And we're often less likely testing patient outcomes like clinical and health status and symptoms. Those have already been tested in the initial clinical trials. And so the next question I usually get is, what's the difference between this and quality improvement? And to me, it's not that much of a difference. It's mostly semantics, but quality improvement is its own method, right? It has its own linguistic and methods and approaches for improving the quality of the patient and provider experience. It doesn't have to start with an evidence-based intervention. It doesn't have to do anything with research, really. You can fix something in the EHR and make it easier for patients and providers. And often I see quality improvement as one of many implementation strategies that we can use to improve the uptake of evidence-based interventions. Health services research is research, right? And so you're testing an intervention using a randomized controlled trial often, and you're looking at outcomes like real world outcomes, right? So adherence and quality and safety are outcomes that we care about in health services research. And then social behavioral science really thinks about theory. And so you're really trying to understand what makes people change their behavior theoretically, that you're understanding the mechanisms and the theoretical underpinnings. And implementation science pulls all of these together. And now you can kind of see why it's such a good fit with this initiative and really thinks of, okay, let's find an evidence-based intervention, design a strategy for helping people and places follow this evidence-based intervention. And then we're going to test to figure out, why did this work here and not here? What were some mechanisms by which this worked in this setting or not? And somebody mentioned frameworks and theories. And so we have a lot of theories and frameworks to help us describe and guide the process and help us understand what influenced our implementation outcomes. How did this work? And help us really comprehensively evaluate what we did without having to maybe just focus on one area. Sometimes in clinical trials, you're so focused on just BMI or a clear clinical outcome, you're not thinking about the full scope of different outcomes that you could be focusing on. And so that really allows you to kind of do this in a very rigorous way. And so a hallmark of implementation science, or how do you kind of do some of this work, is we're usually doing randomized controlled trials or step wedge designs or something I can answer questions about if people are interested in. And you're doing more natural experiments. This is something that's happening usually in the real world. And we use a lot of mixed methods, qualitative methods to help us understand why people are not doing something, what's happening here, contextualize some of our findings, before doing mostly randomized control trials and step wedge designs, et cetera. So you have these kind of hybrid, and many of us sit in this kind of hybrid one, right? Where, or maybe even before that, we don't even know if it works. Hybrid one means that there is some efficacy research already. We know this mostly work. We just don't really know if it works in the real world. And maybe there aren't a lot of clinical trials supporting our findings. And so these hybrid one trials are really focused on testing the effectiveness of an intervention, which is where many of you might be, while also collecting some implementation outcomes and getting a sense of what would it take to widely implement my intervention across the state or across the country, for example. And then hybrid twos, you're doing both. You're still testing your intervention. We're trying to figure out if it works in the real world while also starting to pilot a strategy. So maybe some training or getting some people to do it themselves in the real world as opposed to having researchers involved. And then hybrid three is when we know this works. We don't need another clinical trial. And our primary focus is trying to improve the uptake. And so the types of research questions you're asking yourself, so for a hybrid one trial, so many of you are here, what are some barriers to widely implementing this program? You're asking stakeholders, you're asking patients and providers, what would make you or help more providers like you refer patients to this program, right? You're getting ready for implementation. And then if you're doing a hybrid two trial, and so I do a lot of these at two and threes, we're now testing different strategies. So it's a technical assistance and reimbursement versus just doing training for clinic directors and all of the different staff. Which one of those were more likely to improve the uptake of this food as medicine, or maybe you have an RX program in your clinic across New York State? That would be an example of the type of implementation or hybrid three trial. Was it cost effective? What was my reach? How many clinics said yes? How many clinics wanted to do this, right? And so you're thinking about a much broader scope sometimes in hybrid three trials. And there's now a lot more interest in understanding mechanisms. Like, how did this strategy work? Why did this strategy work? Did we actually target the barriers that we realized were barriers initially? These are all the reasons why it's so hard to do this. We now targeted using an implementation strategy. Now there's a lot of interest in understanding were the mechanisms different in one group versus the other. Did we really make an impact? They're trying to get a sense of what are the most cost-effective and efficient implementation strategies. So, how do you do this when the evidence is very strong, right? And so some of us are here and some of us aren't. So if you think your evidence is very strong, then you're following this more or less four-step process. And so we put this out in um, our scientific statement of how to leverage implementation science to achieve health equity. And so these steps have been shown before. You're selecting an evidence-based intervention, you're understanding why it's so hard to implement, you're then selecting a strategy to get people and places to follow that evidence-based intervention, and then you're evaluating. And we created this checklist, and it's available with the AHA, where you can go through and make sure, am I doing this from an equitable perspective? Did I involve stakeholders, particularly from historically marginalized populations, at every step? Did I apply equity-informed implementation science theories, models, and frameworks? Did I think about the social and structural determinants of cardiovascular health equity in every single one of these steps? Am I thinking about quality, not just of the evidence-based intervention, but the strategies? Now there's a repository of strategies. We kind of know which ones are more effective than others. And so hopefully you're choosing one where you know there's technical assistance is one where an expert will help a clinic implement something, right? That's now been shown in multiple different types of settings and interventions to be a very effective strategy, right? So you're selecting something with high quality, and then you're considering adaptation at every single one of these steps. So we have this nice, easy to follow checklist that you can kind of use as you start thinking about implementation science for each of your own projects. So for step one, you want something that, and this is where the evidence, some of you are not here yet, but you're really looking for something where there is proven evidence. We have programs and guidelines, and there's an evidence to practice gap. Right. And so there are lots of resources to help you figure out what is evidence-based. You can look at the USPSTF, there are guidelines, Cochrane collaboration. You can find systematic reviews. There are review groups that can tell you, okay, this is the most evidence-based, especially if you think you're a clinic director, for example, or administrator at a big hospital system. You really only want to implement the things that are the most evidence-based, right? And so these are resources that can help you figure out, okay, this is ready. This is something that I'd want to. And in terms of trying to decide, you're thinking about what are the population characteristics and needs here. It's not just the best available evidence. It's also thinking about, do we even have the resources to do this? And you're going through, there's an implementation science at a glance. It gives you a nice snippet. And I think all these resources will be available to you to get a sense of the kind of evidence that is the most rigorous when you're thinking about selecting something. And the reason I tell you guys this now at your stage is that you want to be designing something that will eventually be accepted by guidelines and part of a systematic review. Right. So this is the why it's so important to do things so rigorously. And people are going to be asking who created the information, what methods were reviewed to review the evidence. You're really doing a very kind of rigorous view here, not just a quick internet check, but of a quick, rigorous view of like, is this evidence-based? And my hope is that this initiative is going to be contributing to that evidence as we kind of go forward. So as you're preparing for implementation, so it's evidence-based now, right? There are guidelines that support it. Your next question is there a research to practice gap? So if everybody is implementing this program, there's really no need for implementation science. You're really asking yourself, does it fit here? Right? In my organization, will my organization be able to do this? Is it compatible? Have people looked at the harms and the costs? Are we, the staff, ready? How would we get ready? What will we need to do? How are we going to evaluate this? This is you starting to prepare for implementation. If you're still at there's no evidence for this, then you're still at the kind of innovation, development, and efficacy testing. So another key piece, I went to a talk a couple of years ago. Ron Adner has a book, The Wide Lens, and he made a really interesting um, statement. And he said, if it doesn't work for every single one of your stakeholders, it will probably fail. So when you're thinking about implementation, it needs to be something that's going to work for policymakers and industry and systems, clinicians and patients. And I think this is something I think the initiative is going to be grappling with is how can we make this work for everyone? If it doesn't work for everyone, then it's going to be really, really hard to implement. Even if one person hates it, it may shoot your entire intervention kind of in the foot as you start thinking about implementation. And the last step before you kind of start moving forward is, do I need to adapt this? You might be thinking about this yourselves. There might have been an RX program, or a coaching program that somebody else had already shown some initial efficacy for, and it was pretty effective, right? And you're trying to see if you can make changes. We should be doing this in a very careful way, right? So green light changes are usually minor, right? Like the program name or some tailored language or pictures, some cultural indicators. Once you start making really substantial changes, like adding activities or saying, hey, originally this was a 12-week program, I'm going to make it 6, then you might be changing so much of it that it's going to be really, really hard to show this similar efficacy, right? And so all of us, when we're getting ready for implementation of any one of our programs, we really want to get a good sense of when you look at the original clinical trials, you want to get a good sense that people were able to adhere to the whole entire thing, right? And so there are lots of interventions where in the trial it was null, but nobody actually followed the intervention. People did one of 12 of the sessions for some kind of educational intervention or behavioral intervention. So really getting a sense, even in the original clinical trials, of what the fidelity was, right? And how much it took. What was the active ingredient? Maybe people didn't use anything else but these 15-minute sessions over the 12 weeks, right? Maybe there's something that was and this is something that I think the NIH is increasingly interested in, is getting a sense of what the fidelity was and what the active ingredients were of an intervention. You can't implement something if you don't know why it worked or why it was effective in the first place. And so as you're designing your interventions, you should start thinking about that. Am I measuring fidelity so that other people can replicate what I've done? Am I giving a sense of any adaptation so other people know what needed to change to make this work, right? And really being rigorous about this and doing this in a very systematic way. So a good example of an evidence-based intervention is the diabetes prevention program. They showed a reduction in incident type 2 diabetes. And so now it's a guideline recommended by ADA and CDC. It's now increasingly reimbursed, and you know what you need to get this done. There have now been trials thinking about, okay, this can actually be as effective if you have a digital or Zoom delivery for this, right? And so, or phone-based delivery for this. And so these are all the things that have kind of happened to get people ready to get this evidence-based intervention more widely implemented. So once you have your evidence-based intervention, you start thinking about context. And this is still some of the stages where you guys are. So you're developing some evidence-based intervention. You're starting to think about, okay, why would it be hard for other settings, not just me, to widely implement this? And so there are these theories, models, and frameworks. This is a schematic of something called CFR 2.0 that really allows you to really think about this from a rigorous perspective. There are interview guides for CFR, and it allows you to, and you can, it's very hard to ask all of the questions, but you can select questions that make the most sense to you, right? Of getting a sense of, is it the resources? Is it reimbursement that's going to be one of the reasons? And you're talking to lots of stakeholders, not just the patients and the people who delivered, but also policymakers and administrators at your clinic and people outside of your setting to get a sense of like, what would it take to really implement something like this? Who are the individuals involved and what do they think? How about the innovation itself, right? And so is it something that's easy to make changes to? Is it trialable? Is it too complicated for many settings? What does it look like, right? What's the evidence for it? And so you're really starting to kind of ask yourself some of these questions. And so here's an example of one author looked at barriers to implementing nutritional interventions in food stores, right? And so things like consumer preferences and demands, having to supply healthy products is an outer contextual factor. You have to think about commercial viability as a store and your layout and insufficient knowledge and work, capacity. Routines regarding waste avoidance is another issue. And then just thinking about the intervention itself, it's the money and resources needed for something like this, for these nutritional interventions. Does it always fit every single setting? Maybe not. Those trade-offs that you start thinking about. And so as you start thinking about your own interventions, I'd love to hear from people if they have any thoughts of things that they can already think of that are going to be big barriers to widely implementing their programs. Any thoughts so far from people? Welcome to put it in the chat. Things that are coming up already that you can think of that are going to be very hard to make this digital literacy. It's good. Yeah. This is like a patient level potential barrier. Any other bigger picture barriers on the outer setting, for example? Who's going to pay for a program like yours? Our program has an educational component and the rates of accessing the edu. Okay, very good. Yeah. Measure food waste and consumption. It's another really good one. So starting to think a little bit of not just your context and your small program, but if others were to have to replicate what you did across a state or across the country, that's what we're trying to start getting you to start thinking about a little bit, right? Expectations about charges beyond those paid for the intervention. Yep. And who would pay for this once the research is gone, once the funding is gone, right? These are other things of just sustainability. Yeah. Good. Okay. And then there are strategies. There's already a lingo for this, right? And so there are about 73 of these, and you're basically going through all your barriers, and hopefully you've done a good enough job of thinking about it from a generalizable perspective and thinking about what it would take to get this done. Is it that you're going to need some kind of fiscal financial strategy, education strategy? Maybe if the educational materials are not working, you need something else. Maybe people are more visual, they need a different type, or you need someone to deliver those educational materials, right? You're starting to think about what would it take to deliver the core components of my intervention. Do I need to adapt and tailor it? Do I need some kind of assistance for clinics to get something like this done if the researchers weren't there? Do I need to change the infrastructure in some way? And so you're really mapping and thinking about your barriers and mapping them to one of these strategies. And you're creating a bundle in the end. And you're going to test that bundle to get a sense of whether or not other settings can actually start utilizing your intervention. And so we looked across the literature at what were the strategies shown to reduce cardiovascular disease in inequities, and what worked and what improved reach of evidence-based interventions in historically marginalized populations. And if you're in an organization, things like clinician education, audit, and feedback, it's very effective saying that, hey, in comparison to all of the other clinicians, you are the least likely to refer your patients to a food as medicine program. And these are the number of your patients who were eligible for that program. That's very effective at getting people to refer and utilize a program. Care team reorganization. Maybe instead of relying on the doctors, you have an automated way to refer patients, or you find somebody else within the practice who can help do this. Thinking about non-physicians and standardized protocols or other things. If you're in the community, then meaningful partnerships, quality monitoring is something that's very effective, education and training, and then I talked a little bit about technical assistance. And so the last part is really thinking through REAIM. Many of you may have heard about this framework, and there have been some recent publications on clarifications and resources for this framework, because there are a lot of misconceptions about this. So REACH is really thinking about the individual level, right? So the absolute number, proportion, representativeness. You might be thinking about collecting some of these yourself at this early stage, right? So for a social risk screening intervention, they looked at the percent of patients who completed the screening and what were their demographics. It's not just how many people did this, but the representativeness of who was able to do your program. Effectiveness, we already know, is impact on clinical outcomes, right? And including negative outcomes, anything around cost, quality of life, other things are things that we care about. And then adoption, there's a lot of misconception. This is the number, the absolute number, proportion, and representativeness of settings and agents who are willing to initiate. So if you went and asked multiple clinics to participate and only one said yes, that's data, right? That means that clinics were either not interested or not ready. So getting a sense of the percent of settings willing to adopt, in an example, a collaborative care model is something else that's been shown. And then implementation happens, really, you're thinking about fidelity to various elements, not just one. So that educational material is a good example. People didn't use the educational material, but they used this. How long did they spend with it? What were some adaptations you had to make over time? Attendance at trainings. Did people go to all the sessions? And then what were the components that were delivered that we wanted people to deliver? And then maintenance is really thinking about this long term, what are usually around 2 years, and without the research in place, are people still doing this even without your grant funding? There have been movements to start to thinking about this from an equity perspective. So PRISM and REAIM is a kind of expansion of the REAIM framework and really thinking about context. And so there is this movement to make sure that you're co-creating and you're aligning with the priorities of the community, which I think all of you are doing. And then thinking about contextual factors of drivers of equity, what is the infrastructure that you're going to need to keep sustained over time, who's not at the table that should be at the table for the intervention that you have. How are you planning to ensure equity in terms of its functions and forms for the strategy itself? You're going to need to adapt it over time. And then for every single one of these REAIM outcomes, you can see how this is a nice lay of there's context, there's the intervention, there's the strategies, and then there are the outcomes. And we want to get a sense of maybe it was hard for people to adopt this or settings to say yes because it would have been too expensive for them. Maybe there are hidden costs that you didn't think about. Maybe from implementation, maybe you have to implement this differently in different settings. Maybe there's low literacy, and that's the reason why this component was very difficult to kind of implement. And then if you don't have high reach, you're starting to think about, well, how do I improve participation? How am I tracking the representativeness of those reach so that it's not just focused on my overall number, but who was there? And then really thinking about subgroup analyses and equity assessments, even at the effectiveness stage. So here's an example of one program, and it was a hypertension prescription program, and it's produced prescription program for hypertensive patients. This happened in 3 safety net clinics and 20 farmers markets. Their strategy was to help clinics create this process screening referral rate. So they met with clinic directors and staff twice a month to help them create the process. They helped them integrate scheduling within the EHR, create and disseminate patient counseling and education materials, and then train the farmers market staff about vouchers and how to kind of do this. That's the strategy to get people to actually fill this out. And their outcomes, they looked at the number of people screened and enrolled and how much money was redeemed and some determinants, right? What were some of the barriers and facilitators as well? So some of the weaknesses are that we don't really know what the evidence was for the Produce RX program. The strategy was not really theory informed. Why did they choose that? Was it targeting certain barriers? There's no framework for outcome, right? We see the percent screened, but we don't really get a sense of what the denominator was, how many people should have been screened, what was the reach here, and any adaptations they had to make over time or fidelity. And so this is the hope, is that we would get closer and closer to doing this in a more rigorous way as you guys kind of start thinking about implementation of your programs. And so, programs like collaborative care, I'm giving this as an example so you can see where I think the field is going, are way ahead, right? And so this was a program that was very complicated. This is a collaborative care program where you basically screen for depression in clinical settings, including cardiology settings. You have a primary care and a care manager who provides treat to target therapy for patients. And then they meet with a psychiatrist once a week to kind of review the cases. So this was first looked at in one clinical trial, then many, and then over time, 100 clinical trials were able to replicate the findings. You have systematic reviews, you have guidelines, everybody's saying these are the programs that we should be doing. It makes sense. It's been replicated in lots of different settings. It's been shown to reduce disparities and inequities and access to mental health care. And then people looked at barriers. Now there are systematic reviews of the barriers. Well, who's going to pay for that care manager? Who's going to train that person? Who's going to deal with issues of insurance and reimbursement and deal with all the patient barriers, right? So that all of that data came out. And then as part of a demonstration project across New York State, we said, okay, to address these barriers, we're definitely going to need some training. We're going to need some technical assistance for the clinics because they have to figure out how to do this program, how to get people embedded in the program. We have to give them money and quality monitoring. We have to come up with a way for Medicaid to reimburse this program, right? It's fee for quality. And then we evaluated the program over time. And so we found great adoption, right? Over time, clinics realized I actually can't pay for this program without being part of the getting reimbursed from Medicaid, especially the FQHC. So they were able to reach 80% of all FQHCs. There was high fidelity. People attended all the training. The care managers wanted to go to the training so they can figure out how to do this in their sites. But people didn't really the clinics didn't really use the audit and feedback or even the billing, which is very interesting, makes you wonder about fee for quality. They just felt like it wasn't worth their time and effort. They billed overall for enrolling patients, but not for the fee for quality component. Then they were able to keep maintaining over the years. And we found as we start looking at mechanisms and other things that it's only those clinics who were able to do all three: bill, attend the technical assistance, do some of the audit and feedback. Those are the ones where you saw improvements similar to the clinical trials. 52% is what the original clinical trials showed. And then we looked at mechanisms. And so we went back to those clinics a couple of years later, and they were less likely to talk about training and funding and some of the early barriers. It gives you a sense of how that strategy was working. And then we circled back and we're like, okay, things that are still problems now are patient engagement and personnel resources. And so maybe we need to add on a strategy in the sustainability phase of some of the work that we're doing right now. So that gave you a little bit of a snippet of, let's say you have great evidence. What if you don't have the evidence and you're still starting to develop your intervention or you're still testing your intervention? And so I think many of you are already doing some of this, is starting to leverage user-centered design. There's been several publications coming out of how to kind of merge user-centered design and implementation science. And so many people might already have an evidence-based intervention that's not easy to fit into a context. And so we're thinking about how do we improve the usability of that very complicated evidence-based intervention? How do we design and think about concepts and build before testing? And this can be used to really think about before you even start, well, as you're designing your intervention, you're thinking about all the different components of one day, many clinics are going to be using this. How do I make this as simple and usable and user-friendly as possible? And we do a lot of prototyping and showing different stakeholders before we even start implementation a lot of the time. So people can see a prototype of what we would be doing, refine it before we build it, and then start testing the efficacy. The other thing is start thinking about reach and effectiveness. So, what kind of program are you developing? Is it something that's going to reach lots of people, or is it something that's going to be very, very effective? And we're finding that it's kind of hard to do both a lot of the times, and they can be very reciprocal. If you have a very rigorous program that includes coaching and like 50,000 components, it's likely going to be effective, but it's not going to reach a lot of people. And we've seen this with some of the tobacco cessation, right? So maybe just giving some counseling by the doctor is not super effective, but it might reach a lot of people compared to kind of the tobacco cessation programs where very, very few people actually get through those. And so starting to think a little bit about how can I balance these two as I'm kind of designing my intervention and starting to test the effectiveness of this. And then leveraging frameworks in your design. People don't always think to do this. And so here's another schematic of CFR 2.0. One of my mentees finished doing this. So she looked at cardiac rehab programs. And so looked at all the barriers, especially during COVID, to implementing cardiac rehab programs. There's social distancing and overwhelmed healthcare system and limited number of staff. And then she looked at all the barriers to implementing home-based cardiac rehab. You have to reimburse. You also need staff to do this. There's patient safety, et cetera. And then design an intervention that would target those contextual factors. So thinking about reimbursement, having to bring some people in sometimes to maximize reimbursement while doing it remotely to make sure that patients felt safe. So created this kind of hybrid program as a way to ensure that she was really targeting all the contextual, inner contextual, outer contextual, really even at the end is now testing the efficacy in her first R01. And some of the outcomes that you might want to add if you're not already doing this is I think many of you will probably be tracking program completion and adherence, no-show rates, duration, but also implementation outcomes. There are measures or validated measures like feasibility and acceptability and appropriateness that people are increasingly looking at to get a sense of if people really hate your program, or don't find it acceptable or don't find it appropriate or feasible, that's something that you want to be kind of aware of before you start thinking about implementation. And then also starting to collect barriers very early on, even in your pilot phase of how difficult it could be, and using some of our implementation science frameworks like CFR 2.0 to contextualize all the barriers that you're eliciting from patients and providers and staff members and administrators and community members and other individuals who might have a lot to say about the viability of your program long term. This is a little bit different. So I talked about using user-centered design. I talked about using theory, and many of you have learned a little bit about the behavior change wheel. And so we use a lot of that in designing both our strategies, our interventions. And so really thinking through, so for depression treatment and screening, they talk to all thinking about all the barriers from the provider perspective. This is less contextual, as you can see, than CFR 2.0. This is really thinking about behavior. What would it take to change somebody's behavior? Is it motivation? They just don't care. They think this is not their problem. Patients feel like they don't have resources and there's lack of motivation. And we use this to map them to behavior change techniques and created a tool that included lots of behavior change techniques within it, right? So this is patient facing, and at the clinician level, we had more problem solving meetings and presentations and other things to kind of get them to with behavior change techniques infused in each of those strategies to help people to follow these guidelines. And then as you're also thinking about and it's not too late to do this, it's never too late, but really thinking about naming things and defining, somebody's going to need to replicate what you did. So who delivered what and how often? What did they have to do? Who was the target of that intervention? How long did it take? And when was it delivered? What was the dose? What's the dose that each patient is getting? What are some of the outcomes and justification for any changes that you've had to make, for example? And then my other piece is really thinking about tracking adaptations, even at this phase. And so if you've had to make any change at all, it's never too late to start at least keeping track of what change did you have to make? Why did you make it? Was it planned or not planned? Who was involved in this? Was it the stakeholders who said that this had to be changed? What was modified? What level of the delivery? Was it at the individual level? Was it the practitioner level? Some of the reasons, the nature. And so there are all these frameworks available to start, and I think can be used earlier in the process to start to give people a sense that people are not reinventing the wheel. And I think that's one of the hopes of implementation science is that you're not starting from scratch each time, that you can read something and get a sense of everything that somebody had to do so that you don't have to make the same mistakes when you're doing your intervention as well. So I left a little bit of time to kind of answer people's questions about their own projects and other things that are going on. But my hope is that you got a sense that implementation science provides some tools and frameworks for explaining why and how and where strategies work or not work. If you have very strong evidence, then it makes sense to follow our four-step process for identifying the evidence-based intervention, examining barriers, testing strategies, and then thinking about evaluation. And then if your evidence is still emerging, like I think many of you are in that stage, then really thinking about leveraging some theoretical frameworks and measuring implementation outcomes early, thinking about barriers and facilitators, and even the mechanisms by which what the active ingredients are of your intervention, because that really goes a long way when people are ready to follow the kind of four-step process of knowing, okay, we want to implement what you did. We need to know why it worked and what are the key components of your intervention as well. And then that's pretty much it. Happy to answer any questions if people have specifically about their own projects, and we can kind of go from there.